So today I want to talk a little bit about, I know it's heart month, and so, we generally come in here with a heart talk, and there is a little bit of heart associated with this today, because, I have a lot of people that come to my clinic, and their legs are swollen, and their main concern is, do I have heart failure? What's wrong with my heart? And that's a fair thing, in that sometimes swelling of your legs can be a sign of something wrong with your heart. But I want to talk a little bit today about some things that may not necessarily be that you have a heart problem, but it still kind of shows up the same way. So this is it's hard to read, so I'll walk you through it. So the first kind of mention of blood vessels and veins was actually back in 1550 BC, that there was a papyrus that talked about swollen veins. And Hippocrates, you may remember Hippocrates, remember doctors take the Hippocratic Oath, do no harm, that's that same Hippocrates. He actually talked about treating swollen veins with compression. Well, move ahead now here into kind of the early ADs, and they started talking about ligating, meaning to tie off veins. If veins were swollen, you would tie them off. And this guy, Galen, he was actually going in there with a little hook and pulling some of the veins out through the skin. So in the 1850s, they started talking about injecting veins. We're going to take some sort of irritating fluid and we're going to put it in the veins and we're going to close them off. And back in mid-1300s, they were doing a thing called vein stripping, which is actually a surgical procedure where they make little incisions in your leg and either pull that vein out or turn it inside out. And that's just kind of the surgical way that this has been done. And for a long time, surgery was kind of the only way to do it. There were some guys that were even kind of filleting your whole leg open and taking out the vein and then sewing it back up, which does not sound appetizing to anybody. And so finally, let me go back. Finally, here in the 2000s, people started talking about ablation. And I'll get more into that in a bit. So first off, we need to understand the difference between arteries and veins. Arteries mean any blood vessel that's taking blood away from the heart. And veins are any blood vessel taking blood back to the heart. There are two different kinds of vessels. And so if you look at an artery, here on the left, this is just a cartoon. The middle part here, this red part, is the muscle layer in the artery. So if you think about arteries, your heart pumps and pushes the blood forward. Well, then your heart has to relax, it fills up with blood, and then get ready for the next beat. Well, what keeps the blood moving forward? It doesn't go like this. If you puncture yourself, the blood keeps flowing all the time, right? So the muscles in that artery squeeze on that blood to keep it moving forward. So if you look at arteries, they have a very thick muscular layer to keep your blood going out and down into all your capillaries. On the other hand, veins are very thin-walled. They have a teeny bit of muscle, but they don't really contract. They're more of a tube than they are anything else. And so they don't really push the blood back to your heart. So you say, well, how does it get there? So this is actually a picture under the microscope of an artery on the left and a vein on the right. And you can see how much thicker the artery is than the vein. And actually you can see here how easy it is to collapse that vein, where the artery stays, for the most part round. So this is kind of an actual picture of the tissue that I showed you in cartoon form before. Now, quickly, a little anatomy lesson. We have two sets of veins in our legs. We have what are called deep veins, and we have what are called superficial veins. Deep veins are the ones that kind of run down towards the bones. They follow the arteries. So you have a femoral artery, you you have a popliteal artery, you have an iliac artery. And so the veins, because they follow this line, it's a pretty straight line down, kind of have the same names of the arteries that they run with. Now these are the deep veins, down on the bone, iliac veins, femoral veins, popliteal veins, and then the smaller ones below. Now, before we move on to the superficial veins, I wanted to spend a touch of time on a real problem and a thing I think people worry about when they see a swollen leg. And so, what I want to talk about is DVT, which stands for deep venous thrombosis. Other name for that is a blood clot, and pulmonary embolism. That means that the blood clot traveled to your lungs. So, this is annoying. This is very dangerous. So pulmonary embolus is nothing to play around with. There was actually a study, 25 years ago, that looked at people that died when they were in the hospital. And 25% of the time they died because of pulmonary embolus. And so you can think about it, you know, when you're in the hospital, are you up and walking around like you normally would? No. Are you laying in the bed 18 hours a day? Yeah. So you're much more prone to get a blood clot, which could then travel. And if any of you have been in the hospital, you know, sometimes they'll give you those little shots of Lovenox in your belly. You know, that's so that you don't get a blood clot because you're laying around so much. Well, let's kind of talk about it more from how it would be as an outpatient. More commonly, when you have a DVT, you'll see leg swelling, but usually it's only on one side. So you'll come in with a big left leg and a small right leg. That's not every time, but that's more often than not, you'll have clot in one leg and not in the other. You'll see inflammation of the skin. It'll be, you're right, the leg that's affected will be red, the other leg will look normal. You might get shortness of breath. Now, not just from a clot in your leg, but if this clot in your leg ended up in your lung, you might have shortness of breath. You might get acute chest pain. Sometimes you may even be so bad that you cough up some blood. You can even have it so bad that you, what we call hemodynamic collapse, or you may show up in shock. It can get that, you can get that sick that fast. So pulmonary embolus is nothing to play with. So it's usually diagnosed by a combination of CAT scans. So if you go to the emergency room and you've had some shortness of breath or some chest pain, you might notice that a lot of times they'll do a CAT scan on you. And what they're looking for is this pulmonary embolism, okay? And then we do an ultrasound. You can't really ultrasound the lungs, but we can ultrasound the leg to see if there's a clot there. Clots don't start in your heart or your lungs. They don't just form there all of a sudden. That clot came from somewhere. It either came from your leg, it can come from your pelvic veins, but it started low and came high, because a clot is a lot like Jell-O. And you know, if you took a Jell-O mold and you drop it on the ground and it goes into 100 pieces, that's what can happen with clots. So pieces of it can break off. It's not this stable thing. It's very gelatinous, and I'm actually going to show you a picture of one here. So this is how we kind of do the ultrasound, and this is a little bit tricky, but on the left here, this is a normal ultrasound. So you can see the artery here, and then the vein right there next to it. The thing that sets the two apart is when you put some pressure down on them, the vein will collapse. And we saw that in that slide, where the vein was collapsed and the artery was more open. So this is a normal ultrasound of the leg, with an artery that stays open, veins open. When you compress it, the vein closes. Now, if you've got a blood clot in your vein, there's something in the way, right? You can't push the whole vein down. So over here, you can see the artery and the vein are open, but once you kind of put pressure down on it, and it's a little hard to see, but there's some foggy stuff there in the vein, but you can say, even when you push down on the vein, it doesn't collapse. That's what we're looking for to diagnose a DVT. And here's another picture, cross-section. You can see all three of those veins. You see all that kind of cloudy stuff in there? That's all blood clot. So that's what a DVT looks like. And so this is actually, usually these happen in the deep veins. That's why I'm starting on this. You can get some blood clot in the superficial vein. So this is where the superficial vein kind of connects to the deep vein, because they do connect together, but you can see clot all in there. This is probably clot that started in the deep vein and just extends a little bit into the superficial vein. When you get clots in your superficial vein, they don't tend to travel. So that's a thing called thrombophlebitis. You may have heard about phlebitis on the leg. That's usually when you get blood clots in the superficial veins, and they rarely, if ever, travel. It's the ones that are in the deep veins that you got to worry about. Now, what happens? So, like I said, the clot didn't start in your lungs. It started down here somewhere. And it comes up here. This is called the inferior vena cava. So the heart is actually, it's not part of the problem. The heart's kind of the passageway, the conduit. It goes through the heart. And so it goes up through the heart, through the right atrium, right ventricle, and out into your lungs. And the problem here is you see those clots, those little pieces of jello, eventually kind of get caught up, because those vessels in your lungs get smaller and smaller and smaller. And if it finds a place it can't get through, it sticks right there. And so that's bad, because it can raise the pressure in your lungs. It can put pressure on the right side of your heart. You can actually develop right-sided heart failure. So it's a fairly big deal when that happens. So this is a video of the heart. And this up here is the right atrium. So that big tube went up and connected right there. That's the right ventricle, and that's going to pump the blood into the lungs. Those are the left side. That's pumping the blood out to the heart. So the left and the right side of the heart are two separate things. Right side of the heart pumps the blood to your lungs so it can get oxygenated. Left side of the heart pumps blood to your body with blood that's already oxygenated. But to prove that kind of your heart is the conduit, see that thing floating around in there? That's a blood clot on its way to the heart, or in the heart and on its way to the lungs. So this kind of proves that, yeah, that came up in there, and this one just hasn't happened to made it to the lungs yet. So what you can do is do an angiogram. An angiogram is like in the cath lab when we put dye in the lung. And so you can see this is the right side of the lung. This is a normal angiogram catheter. But do you see how every part of the lung gets dark when you inject it? This is the left side. Every part is dark. We look there. See how it doesn't fill in right there? That's the clot that's all wedged in there. Right there. I think I got another one. This one's even better. See how none of that area of the artery fills up? That's all full of clot. And so just a little bit of dye is squeaking down the way. And so you can be sick with this. So generally the way this was treated in the past, so let me show you this. We now have some tools. We don't do this here, but up at Grandview we do it when people are really sick, where we can actually go in with a catheter and suck all the clot out of the lung, which really works very slick. And this is the clot that was pulled out of somebody's lung. And so you can see it's kind of gelatinous looking. It kind of takes the shape of the arteries in the lung, and so that's why it causes such a problem. So what is the treatment? The long-term treatment, traditional treatment of DVTs and pulmonary embolus is anticoagulation, which means blood thinner. So for DVTs, back in the day, you used to get put in the hospital, they'd give you liquid heparin in your vein, you'd hang out for 3 days, and they'd give you some medicine to take by mouth. The traditional medicine was called Coumadin or warfarin. You probably all have heard of that. We now have other medicines that we can give, the Eliquises, the Xareltos, the Pradaxes of the world. We tend to give those now. And now the treatment for just a blood clot in your leg really is an outpatient thing. You know, go to the emergency room, swallow the leg, you got a blood clot, they give you medicine and send you home. So you don't even have to go to the hospital for the most part, unless you have a big complication or a really big DVT. A lot of times I'll even treat it for people that come in the office, and if I find they've got a blood clot, start them on some blood thinner and let them go home. Now, Pulmonary embolus is almost always treated in the inpatient. Patients are much sicker. We'll start on IV heparin. We also have medicines now. So thrombolysis means we give you clot buster drugs, which work really good, but there's a real bleeding problem and a bleeding risk with those. So they've kind of fallen out of favor. And thrombectomy actually means we go in there and we excise that clot, which is what I showed you, those red, icky worms that we pulled out. So that's done in the cath lab. Now sometimes patients that have a blood clot, let's say they can't take blood thinners because they've got some other bleeding problem. Or we see this a lot in the population of people that have cancer because they're a little more prone to having DVTs. So let's say they got a blood clot in their leg, but they can't take any blood thinner because maybe they're having stomach bleeding or they knocked their head and had a head bleed. And so what you can do is put in what's called an IVC filter, which is a little filter that goes down here in your vein. And the idea of that is, okay, sorry, you've got a blood clot in your leg, we don't like it, but we don't want it to travel to your lung where it can become dangerous. And so that filter helps keep the blood clots from going up towards your lung. Most of the time, if it's your first time of having a blood clot like this, you got to take blood thinners for 3 to 6 months. The reason people get blood clots are various. I said one, cancer. Sometimes if you've been in a long trip, if you've had trauma or an operation to your leg. The wrong one. You know, if you're on an airplane, if you're on a bus, you're in a car, you really want to make sure you're getting up and walking around every couple of hours to reduce your risk of getting a blood clot. Certainly if you've had a hip replacement or a knee replacement, the greatest fear of most orthopedic surgeons is that you get a blood clot. And, if you think about it, you get a hip surgery or knee surgery, you don't really want to walk around in it because it hurts. And so you don't get around as much, and so you're at risk for blood clots. So let's move on to the superficial veins. So the superficial veins are here. They're really run out more kind of just under the skin. Now if you look at this picture and you see that line that goes down the middle, that's the femoral vein, that's the deep one, okay? But these little blue ones are the superficial veins. The most common one you've probably heard of is the saphenous vein. That's the one sometimes they'll take out for bypass surgery. But your saphenous veins, they run all out here underneath your skin. You also have one called the small saphenous vein, which is really kind of on the back of your thigh, your calf. So these are a little different. Now, like I said, veins don't have a lot of muscle. So, if they don't have a lot of muscle, how are they going to keep the blood moving forward? Well, veins actually use the muscles of your legs when you walk or you exercise or anything like that. As the muscles are contracting, it kind of milks the superficial veins. That's what provides that push to get that blood back up to your heart. And so, the other thing that veins have is they have valves. So if you think about it, the muscles are pushing the blood up. You want it to go up, but you don't want it to come back down. And so you have a valve, and when the blood comes through it, the valve will open. And then when it's not being squeezed, then the valve will close. And that keeps the blood from going back, back on down. And you can see this on an ultrasound. This is an ultrasound of a vein, and you can see right there, that nice wispy valve is closed, and it's doing its job from keeping blood from going backwards. Now, what are the risk factors for having venous insufficiency? Obesity, age over 50. Certainly previous pregnancy is a risk. If there's a family history, or if you've had a history of blood clots in the past. Because if you've had a blood clot in the past, that can actually damage the veins. And so then they're more likely for the valves not to work right. Smokers have a higher risk, and it's definitely more prevalent in females. So what's the signs and the symptoms of venous insufficiency? Now remember again, we're talking about the superficial veins now, not the deep ones. The deep ones tend to cause problems with clots. The superficial ones tend to cause problems with swelling and varicose veins and things like that. So this is not exclusive. You don't have to have all these things. You may just have some of them. So definitely swelling. That's what usually brings people to the doctor. They have kind of unexplained swelling, which is, the medical word is edema, in their legs, can go all the way up into their thighs. They'll have a dull ache or cramping in their legs, particularly if they've been standing for a long time. You may have tingling or burning in your legs because that fluid in there kind of stimulates your nerves, and your nerves don't like it, and so it'll tell you about that. They may get itchy because the skin of your leg kind of gets stretched out by that fluid, and then you'll get some kind of scaly things on your legs, and those will itch. When it becomes more severe, you can get with varicose veins. So that's when you have all those little swollen ropes in your legs. Those are varicose veins. And then you can get skin changes, and then they can become cracked, discolored, flaky, weepy. They start to look like leather, and eventually you can even develop ulcers, and I'm going to show you that. So this is how we diagnose venous insufficiency. So this is kind of a complex slide, but I beg your patience and let me walk you through it. So I went the wrong way. Can you send me back one? Thank you. All right. So this is the ultrasound of a vein. There's the vein, the kind of bright white line, and then we put some color in it. It's called Doppler, and you can see it's blue because it's a slow flow through the vein. Now, the next thing we do is we put a little compression down there, the ultrasound tag, and like I showed you, we're looking to make sure those veins collapse. But what should happen is, when you collapse it, there should be no flow backwards. But if your valve's not working, you'll see what's called reflux. So here is the normal flow, and then they put on the compression, but you see all that flow that happens out there? That's called the reflux. And so we can time that, and there's certain numbers that we don't need to get into what the numbers are. But this tells us that the valves of the leg are not working properly. So we have started doing this at the hospital called a reflux study. Some of you may have had a Doppler, an ultrasound of your veins. Most of those traditionally just looked at the deep veins looking for clots. But now we do a reflux study, which looks for clots, but also looks to see if your superficial veins are leaking like that. And so you can think, I'll show you on the next slide. So here's a normal vein on this side with normal valves, and your veins are fine. Here, the valves don't work as well. So instead of the blood kind of going ka-chunk, 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 it's going up and down, up and down, and up and down. So there's nothing to keep the blood from kind of wanting to collect back down towards your feet and legs because these valves don't work. And so then you can develop these swellings of your veins, and those are called varicose veins. And I don't know, maybe some of you in the room have some varicose veins, so you don't need to see this picture because you can just look down. But for people that don't have varicose veins, you can see they're kind of bluish there, there's swellings there, and so that can be one of the signs that you have venous insufficiency. Now, what's kind of the natural history of these things? So you can start with some little spider veins. Back me up to, I'm confused between the laser button and the, yeah. So some people just have some little spider veins, some little tiny, they look like spiders just on your skin. And that can be your initial sign that you've got some venous insufficiency. And then as you move along, you may get some small veins that are visible on your leg until they become bigger, and then they start to kind of look like those swollen ropes. And then if you don't kind of do something about that, now you start to see changes of the skin. The skin becomes real thickened, it can become irritated and red, and then if you kind of let that go, you actually can develop an ulcer. And I'm going to show you some pictures of that. Now this is kind of the real time what legs look, not just the cartoon. So the way we kind of stage this is called the CEAP score. Doesn't matter what CEAP stands for, but kind of if you have spider veins, you're considered a C1. If you have varicose veins, C2. If that progresses to swelling, C3. Skin changes pushes you into the C4 range. And then if you have an ulcer that's either been healed or active, you're C5 and C6. And so we try and get to people higher up on the stage before we get down here, although we've got a fair number of patients we're taking care of now that are down here. So back in the day, the only, like I was saying, the only way to fix this was to get the surgeons to go in there and cut you and do some tying up and some pulling and some yanking, and you know, nobody likes that. So, because it's a surgical procedure. So they've come up with different ways to deal with these swollen veins, and that's called an ablation. Ablation is just a fancy word for closing down the vein. And you'll say, well, gee, if I close down the vein, how's the blood going to get back to my heart? Well, unlike the arteries, which are kind of just about the same in everybody, the veins have all kinds of little extra branches. And so what happens when you close down that leaky vein is your body actually starts sending the blood down through these other veins that you've got, which is able to get the blood up there. And that don't rely, not every vein has valves in it. And so you're able to get the blood up through an alternative road. But we get rid of the one that's leaking so bad. So the original thought for ablation was, there's kind of a couple ways. First one was called thermal ablation. So they take a catheter and you put an IV in there. So they ultrasound your leg and they kind of find where where's the worst side of leaking, and then you follow it down and you find this kind of smallest area you think you can get an IV in, and you'll put an IV in there. And then they run this catheter up there, and on the end of the catheter is kind of a heating element. And so it'll heat the vein, kind of coagulate the vein, so it collapses because you've heated it up. And that method works. The problem with it is people don't love it because A, it can be a little bit uncomfortable. Think about, you know, put a catheter up in your vein and let's heat it up. That doesn't sound so fun. And so one of the ways that they have to do this, when they do the thermal way, they have to take lidocaine and all along the vein, all the way down, you know, so that you don't quite feel all the heat. And nobody likes to get 11 shots of lidocaine in their leg. But that's how you kind of have to do it with the thermal procedure. The other problem with the thermal procedure is after they're done, they have to wrap your legs tightly in like ace bandages, and it takes a little bit more recovery. You can't just, you know, walk out that same day and go, hey, everything's fixed. Now, there's a fancier method now that people use, which instead of using heat, uses a laser. And similarly, it kind of coagulates the vein, makes it close, but you still have to do all those lidocaine shots down your leg. So there is now a new way to do it. And this is with a substance that's called vascular glue. The name of it is called Venous. Now, the nature of the procedure is very similar to what you did with the heating element or the laser, but instead of kind of heating it up and coagulating it, what we're doing is actually gluing the artery shut. So what you do is you come in, you get draped like this, and we clean up your leg, and we go take the ultrasound and find where's the best place, the lowest place we can get into, and we put a catheter in there. So that part stings a little bit. You do get one shot of lidocaine before we put the IV in, but you don't have to have lidocaine all up and down your leg. And so we put the catheter in, and then we find the spot. So the superficial vein comes up your leg, and it goes into the deep vein, and then the blood goes up to your heart. So what we don't want to do is have some of that glue get into the deep vein, which can cause a blood clot on its own. So we find where the two are connected, and then we back up about 5 centimeters so that we don't put any glue into the deep vein, and we start to glue it. And we we start, you can see the catheter right there, and that's how the glue comes out. And the whole time we're doing this under ultrasound guidance. And so you can see we put some glue in there, holding pressure, and it glues the thing shut. And we do that all the way down to where the IV is. And when we're done, we pull the IV out, and you go home with a Band-Aid on your leg. You don't have to have it wrapped in a big ace bandage or anything like that. And I've actually seen people get this done and then walk out of the hospital on the same day. So it's very well tolerated. It doesn't have all the discomfort associated with it. It doesn't have all the post-procedure stuff that you have to do. And if you look at this, as you can see, this is the end of the catheter, and you can see how that glue gets in there and just glues that vein right shut. And so after that, you do have to get a couple of ultrasounds. About 3 days later, we look to make sure there's no blood clot. And then about a month later, we go back and make sure that the vein is closed. So, kind of simple as that. So this is some of the, what you can see. So this is you see that varicose vein, all those ropey, tangled vessels. And then 3 months after the venous seal procedure, well, that gets much better. And people really legs feel a lot better. Now we've also done people, so this would be considered the C3 level we were talking about. So we also have been working on people that are C5 and C6. Skin looks like leather, it's red, it's flaky, and they have an ulcer. So that's what a venous ulcer looks like. Now, they can get a lot worse than that, but I didn't think we need to, share some of my worst pictures with you. I just wanted you to get the idea, because they can get a lot worse than that. But that is a venous ulcer. They tend to form kind of on the lateral sides, like around the ankle. You can get them up here in the leg. Now, so what's the difference between that and an arterial ulcer? An arterial ulcer means you don't get enough blood flow down. That tends to show up on the bottom of your foot or kind of on your toes. The common thing is like in diabetics who decide it's a good idea to walk outside in their bare feet and they step on a stick. I don't even know what happened, but all of a sudden they got an ulcer on their toe or on their foot and it gets infected. That all has to do with blood supply, not with venous insufficiency. So venous ulcers kind of tend to be more on the ankle or more up here on the lower calf. And so we can even, this one's a little bit worse, still not the worst I have in my slide collection, but you can see that's a pretty angry looking ulcer right there. And so a lot of times we'll do the ablation, and we do a lot in combination with the wound care center here. Quincy at the Wound Care Center does a lot of good work around here, helping people with arterial and venous ulcers. But, if you can't solve the problem that caused the ulcer in the first place, it's hard to heal the ulcer. So if you've got an arterial ulcer, well, the only thing that's going to help that get better is to get better blood supply. Similarly with veins, if you have a venous ulcer, and you have all this blood wanting to back up in the system, it's hard to heal the ulcer until you fix the venous system. So you can see here, this is the venous ulcer, a little higher than the ankle, but still here out of the lateral side of the leg. Underwent an ablation, and now you can see how well it is healed. In a combination of having an ablation followed by some wound care, and the thing pretty well healed. So, in conclusion, when you hear the words venous disease, remember there's deep and superficial veins. And so the things we talk about today include thrombus, that's the clot that forms in your deep veins. And we also talked about venous insufficiency, where the valves don't work. Thrombus, or DVT, is treated with blood thinners, and sometimes you gotta pull the clot out of there mechanically in the cath lab. I think we saw today that venous insufficiency can progress just from having little spiders on your legs to a place where you get varicose veins, to where you can actually develop ulcers and have tissue loss. And then if that ulcer gets infected, then the horse is out of the barn. So you want to try and jump on that sooner than later, and fix that. There are multiple ways that you can have ablations done: lasers, thermal, the glue. Now we are doing the glue here at Coosa Valley. We've been doing it now for right around 5 months. People seem pleased with it. They're tolerating the procedure well, and it's worked out really well for patients. And what I would ask is, if you think you have a problem, chronic swelling or varicose veins or anything like that, talk with your primary doctor. Not to say that I don't want to talk to you, and I'm happy to talk to you, but sometimes you might be at your primary doctor before you come to my office, and ask them to order a reflux study. We're doing them at the hospital. They're easy, they're non-invasive. They put a little jelly on your leg, and they put a little pressure on there. It's not like that, it's just some light pressure, and they can see if you have venous insufficiency. And then if you do, they can refer them to us at ACG, and we can take it from there. Certainly, if you're in to see us and you haven't seen your primary doctor, we're also happy to order the reflux study. But the reflux study is kind of the starting point in this. If you've got symptoms, if you've got what looks like venous insufficiency, we need to prove it. We need to know how big the artery is and how bad the leakage is. And so that reflux study gives us that information, and then we can sit and talk about how we can move forward. I appreciate your attention today, and I'm happy to take any questions from the audience.
Hey guys, do you have any questions?
So, like somebody that has AFib that has had a Watchman procedure, does that help prevent clots from going to the lungs or the brain? What clots is that?
It does not. So in atrial fibrillation, which is a really common reason people are on blood thinners, atrial fibrillation, for people that don't know, is a rhythm problem of your heart. The top part of your heart, instead of beating like this, is beating like that, like a bag of worms. And then it's not really pumping very good, so the blood can pool, and then if it pools, it can clot, and then that clot can go flying, and you can have a stroke. And so the main complication of atrial fibrillations is not that the AFib is going to kill you. It's actually well tolerated, but if you get a clot, it can travel to your brain and cause a stroke. Now, that's on the left side of your heart, okay? That's where those clots tend to form, is on the left side. And so then that clot would go to your left ventricle, which then shoots the blood out to your body. That clot can go anywhere, but that's now in the arterial system. It's not in the venous system. Remember, the arteries take blood away from the heart. And so it can end up in your knee or in your toe. But unfortunately, the first 3 arteries that come off your aorta all head that direction. And so stroke is far more common. And so those patients will frequently take blood thinners so that they don't have a stroke. Now, there is a new device called a Watchman device, which kind of seals off this little, so your atrium's here, and there's this little thing that hangs off of it called the left atrial appendage. I think it looks like a dog ear. It's probably more like a gutter, and those little clots form and they fall down in the gutter. And then when your heart goes back in rhythm, guess what? It squeezes it out. And so the Watchman goes down and fills up that gutter and blocks it off so that you can't form clots down in there. And so the Watchman was originally designed for people who couldn't take blood thinner, like they'd had a previous bleed in the head or had lots of ulcer problems, or wouldn't. There are people that you say, oh, you might have to take some blood thinner, and they'll say, no way. And so, for those people, the Watchman was designed for that. But it has become more now, even for just people that have AFib and they want to get off a blood thinner. The Watchman and blood thinners are equivalent. One's not better than the other. And so people get that Watchman for various reasons, but then they can get off their blood thinner. This is all happening on the left side of the heart, okay? We're talking about clots that form in the right side, go up to the right side of your heart, and then get shot out into your lungs. So a Watchman will protect you from a stroke with atrial fibrillation. It will not protect you from a DVT. It will not protect you from a pulmonary embolus. And so if you're somebody who's, let's say, has atrial fibrillation but you've had 2 previous blood clots, you're better served being on blood thinner than having a watchman, because even if you got the watchman, you're going to have to stay on blood thinner for the clot anyway. Yes, ma'am.
I'm on Entresto,
Yes, ma'am.
and so far so good. It's treated me well.
Yeah.
But I have itchy, twitchy. I scratch so much till I bled,
Yeah.
and I stopped the bleeding.
Okay.
But I have the itchy, twitchy.
Sure. Absolutely. So the question there is that from the medicine or is that from something else? Do you get swelling in your legs?
Oh, definitely.
So it would probably worth having a reflux study to see if your veins are working. You know, is this a medicine problem or is this a different problem? Unfortunately, swelling, itching, sore, tired legs is not specific to venous insufficiency. It can be other things. And you know, if somebody comes, just like if somebody comes to my office with swollen legs, of course, the first thing I'm going to do is make sure they don't have a heart problem before we go looking at these veins. But if
I have congestive heart failure.
and so you may have, you know, people that have congestive heart failure are more prone to have it because their heart's not pumping quite as good as it should. They will get some swelling in their legs, and you can have these kind of symptoms purely because you've got chronic swelling. But I would say it's worth getting a reflux study just to be sure that there's not venous insufficiency down there making it worse. Because if your heart's doing good, yet you're still having this problem, you know, maybe there's something else going on. Ma'am?
How dangerous is it to leave your Plavix off? I've been on Plavix for 15 years.
So,
I've been told recently that I should leave it off.
yeah, so Plavix is a different kind of blood thinner. The blood thinners we were talking about here, the Coumadins, the Eliquises, the Xareltos of the world, what they do is help to inhibit the blood from clotting. Your blood has 3 kinds of cells in it: red blood cells, white blood cells, and platelets. Red blood cells carry the oxygen, white blood cells are the infection fighters, and the platelets are the teeny little things so that, like, let's say you cut yourself here, and you wait for a couple of minutes, and you see how it all kind of gets sticky in there? Those are the platelets getting in there and getting sticky, and then they bring the blood clotting mechanism to clot it off. Now, there's a number of reasons to take Plavix, the most common one around being that people have had previous stents. And so if you have a stent that was put in you, for sure, you have to take Plavix for 6 months. 10 years ago, everybody said do it for a year. Now there's been some data out of Europe that says maybe 6 months is enough. And so you have to take it from 6 to 12 months, depending on what your doctor says, so that something doesn't stick to your stent, right? When you first get a stent put in, it's just a piece of metal sitting in there. Your body says, hey, that's not me. I'm gonna wall this off just like they would a bacteria or a virus, and your platelets will stick to your stent, they'll activate, clotting will come in, and you have a heart attack. So after you've had a stent, a year after, then I think you're safe, again, in consultation with your doctor, to be able to come off of it. Let's say it's a year since you had your stent, you gotta get your gallbladder out. Well, you can't get your gallbladder out if you're on Plavix, so we can stop it for 7 days, get your gallbladder done, and go back on it. Sometimes when people that have had strokes, even though they were taking aspirin, a lot of times if there's no atrial fibrillation, they'll say, well, dude, you had a stroke and you were on aspirin, let's add Plavix. And if that's the reason, then probably you should stay on the Plavix. Now, after a stent, I kind of have 2 groups of people in my practice. And this was much more common when Plavix was expensive. You know, some people will say, well, gee, I've been taking my Plavix all this time, I've not really had a problem, why am I going to stop it, you know? And the main problem being bleeding and bruising. That's the main side effect. And then I have other people that say, you know, in 3 days and 24 minutes, I'm stopping my Plavix because I hit my 1 year and I'm coming off. So I have patients that do both. Some just stop it because they don't want to be on it anymore. Some just stay on it for pertinent or ever. and both seem to do fine. But you have the option of stopping it after a year from your stent. Again, not knowing your whole history.
Well, I had bursted veins in my legs, is why I had to go on it.
Yeah,
And the doctor that prescribed it told me if I didn't take it, I would get more bursted veins, and if I didn't rush to the hospital, I'd bleed to death.
potentially. Although, yeah, so that question you asked is a lot more difficult one than you think it is. And actually, there's now been some data looking at vein problems that maybe low dose Xarelto may actually help it more than Plavix does. So, I wouldn't stop it all of a sudden. But I think it's worth a chat with whoever's taking care of you to, talk about it and see, do I still need this?
I think you did my daughter-in-law's leg about 3 weeks ago up here.
Did I really?
Yeah.
She's doing okay, isn't she? Thank the Lord. Yeah, I appreciate hearing that. Good. Okay.
Well, we wanted a testimony, so there you go. All right.